Perfect.
Thank you.
Thank you.
So the first item on the agenda today is the election of chairman. This is a nomination from the Dorset Council side. So can I have nominations for chairman, please?
Thank you, David. I'd like to nominate Councillor Laura Miller.
I'll happy to second that, Chairman.
Thank you very much indeed. No more nominations because the other Dorset Council rep is Councillor Carr Jones. So, Councillor Miller, you're elected chairman for the meeting.
Fantastic. Thank you, David. So the next item on the agenda is the appointment of vice chair. So from the BCP representatives, if I could appoint Councillor Nicola Green.
Thank you.
Brilliant. Thank you. OK, so let's go back to the agenda. So thank you, everybody, for joining us for this Joint Public Health Board on this snowy, but not very snowy day in February. Moving on to apologies. Do we have any apologies?
No apologies, Chairman.
Fantastic. We are a full complement, which is excellent. OK, item number 4 on the agenda, the minutes of the last meeting held on 5th of November. I assume everybody's had a chance to have a good run through the minutes. Is there any? I don't think there's any anything we need to pick up that doesn't appear in today's agenda. Does anyone have any comments on the meetings, or are we happy to accept those as an accurate record?
Happy to approve them, Chairman.
Fantastic. Thank you very much. OK, those are duly approved. So declarations of interest. Does anybody need to make a declaration of interest of any items relevant to appearing on today's agenda at all? I'm going to take silence as no. No. OK, thank you very much, everyone. OK, public participation to receive questions or statements on the business of the committee from town and parish councils and members of the public. David, do we have any statements or questions from any of those people?
None received, Chairman.
OK, fantastic. Thank you very much. Right, let's have a quick look. Item number 7. So today's meeting, the agenda is quite brief, I think, and for very good reason. The people that are involved in this meeting are currently still sort of with their heads very much within the pandemic. And so I would like to use today's time to go quickly through the forward plan, maybe mentioning along with Sam Crowe, our Director of Public Health, what we would like to really dig into in future meetings. I think the next meeting is proposed as May, and hopefully we'll, very much have our heads above water and be able to look to the future. And I think Sam's going to cover some of those sort of plans in his report as well. So let's have a look through the forward plan. I'm just going to bring it up on my screen. Let's see, where are we? Okay. So we have a briefing today for the Director of Public Health. We have the finance report, both very important, both for noting. And then we've got some question marks over the May meeting. Now that's the annual review of the Joint Public Health Board, and then the finance report, and then the Health Improvement Services performance monitoring. So May includes the business plan as well for the following year. So May, I guess, is looking a little bit meatier. Sam, do you have any comments that you would like to make on the forward plan?
Only to kind of endorse the ambition to get back into a more formal meeting by May. I think it'd be really helpful to look at the business plan in particular, and also a bit of a review over what we've done in the past year. We are going through the process of trying to develop a business plan that's sort of fit for the situation we found ourselves in. So I think it's important that the board sees that in May, and we'll start to get back into our normal rhythm of monitoring some of the public health services. So that's all I wanted to say, really. Let's stick with the ambition. If plans change, we can always seek the board's advice as to whether we need to change course nearer the time.
Okay, fantastic. And, I think the board exists to support as well as challenge. So, I think I can probably speak for my other colleagues, elected members, that, very much want to work with you. Our ambition is going to be to get back to normal business, and really to sort of have a chance to comment and shape those services, because, we're all so hyper aware that we can't let the normal service, fall behind or drop in any way. So I think that's a really good plan to aim for May, whilst acknowledging that time pressures at the moment are still very much with us. Do any colleagues around the virtual table have any comment on the forward plan at all? No, are you all content with the ambition to get back to May? Fantastic. Okay, we'll look to the future then, and move on to item number 8, which is the Sam Crow Show, the presentation by the Director of Public Health Dorset, activities and progress, particularly highlighting the pandemic, which will come as no surprise to anybody. So Sam, the floor is yours.
Thank you. I'm just going to share my screen, so bear with me a minute. I'll just wait for the presentations to come up, and then I'll take you through. I've got hopefully a fairly brief presentation, which focuses mainly on what we've been doing in response to coronavirus, but I've also provided a few briefing notes as to what we need to start to think about as we return to business as usual. So hopefully that's coming up on screen now. Let me know if you can't see it.
Okay, that's perfect, Sam. Okay,
brilliant. So just to set the context, obviously 2020 was a busy year. It wasn't just about COVID-19, although that consumed the way that we work as a team. But just a few kind of briefing notes here about some of the other issues that are potentially, I hope, not going to affect us too much, but they are happening in and around the public health team. So Public Health England, you may remember, is being disestablished. So that's formally from April 2021, although the shape of the new organisation, which is going to be called the National Institute for Health Protection, I don't think will be clear until the autumn. The only question that I think will impact on the way that we do public health locally will be where some of the other employees that supported things like health improvement, public health surveillance, some of the work on health inequalities, where they will sit in the reforming system. So at the moment it's not quite clear, because the Institute's title, as it would suggest, it's going to be very focused on health protection. At the same time, there's draft legislation being looked at to introduce the integrated care systems as formal legal entities from 2022. You may have seen in the press over the weekend, there were a couple of leaked versions of the white paper. There's lots of commentary, and there's some wording within the white paper which makes reference to greater powers by the Secretary of State for Health to direct the NHS to carry out public health activities. That's been interpreted by some people to mean that public health will be sailing back into the NHS. That is not what I've picked up at all. It just means that the Secretary of State has more power to tell the NHS to be very, very mindful of its public health responsibilities. So I interpret it as a strengthening of the prevention mandate within the NHS, not a wholesale shifting of public health back into the NHS. I think the public health functions will remain with councils, but there might be new duties on the public health team around the way that we work in the integrated care system. I think so far, because we've had a relatively strong partnership and we've supported the system through the sort of first wave integrated care system as one of the 10 areas that went first. I don't think that will be a huge material change for us, but it's just worthwhile being mindful of that's happening in the background as we're grappling with the response. We've taken on greater responsibility for the local delivery of pandemic response, supported by colossal amounts of grant funding. So this is one-off grant funding. It comes with fairly stringent criteria that it's to be used to mobilise the response to outbreaks. And I guess my final point about the wider context is that we have to remember there's a limited number of qualified public health people to draw on. So whenever these changes happen, whether it's people moving to and from Public Health England or the new institute, it does have an impact on the wider market of public health professionals. We're all very tired. There's not a particularly strong interim market. So if we need to use some of the grant funding to draw on people to support and maintain our public health team, we need to think through that very, very carefully, because it's not an unlimited resource. So that's some of the thinking that we're doing currently. So that's just the environment, if you like. So in terms of the current situation, the current peak is now receding. We're in a much better place than we were 2 or 3 weeks ago, but it was the worst yet in terms of our infection rates and the number of people with severe disease requiring hospitalisation. So the two epidemic curves that you have here are for BCP Council at the top and Dorset Council at the bottom. This isn't the infection rate, this is the absolute number of diagnosed daily cases, and you may be able to see the chart. The left-hand axis here for BCP Council shows that at the peak we had at some points over 600 cases a day, and for Dorset Council at its peak around about 250 cases per day. But you can see that it dwarfed what was happening in lockdown 2 when we started to go into lockdown during November because of the increases that we saw, partly because of the return of universities and the return of schools. It really did, I think, knock us off our feet and catch everyone by surprise. So the pressure that we felt in the system was directly felt in terms of our care homes and hospital occupancy. It far exceeded that in the first wave, and it's still high, although it is coming down quite quickly now, which is a relief. But just to put the numbers into context, in the first wave, around about the end of April, we had around 130 people in hospital with COVID-19. And at the worst of this second wave, we had around 550 people in the local hospitals. So materially different. And in terms of the way that it affects the public health team, all of those outbreaks that directly affect high-risk settings need incident management team meetings supporting. And the public health team has picked up more and more work from Public Health England in organising, leading and running those meetings. So at the peak, we were dealing with well in excess of 100 incidents per week coming into the team, all of which we needed to mobilise some sort of support for. So just a slide which I've shown over the past couple of weeks. I think although the wave in BCP Council, which is shown in blue here throughout December and January, was very, very different to the wave in Dorset. It was much more pronounced, particularly in the first and second weeks of January. It's still worth, I think, showing that compared with the upper quartile of worst affected councils, we were somewhere in the middle. So these crosses here represent the way that the wave hit the councils in the median. This is the top quartile in terms of the councils that were worst affected, and this is the lower quartile. So we were above the median, very, very different to Dorset. And I've said that it looked much more like the pattern that we saw in some southeastern London councils. And there's a question, were we hit by that new, more transmissible variant? Almost certainly. What we now know is that that's turning up in an increasing proportion of cases that are being analysed in our system, as in many other councils. But I also think the role of inbound travel probably played its part. So the working hypothesis is that because we were in a different tier, we locked down later than London and other parts of the southeast. There was a lot of inbound travel from those council areas just before the Christmas period, and that led to, along with the social mixing allowed over the holiday period, a window where our cases transmitted much more quickly than we would have anticipated, and we had that subsequent rise in infections. So we've requested some national analysis of telephone data just to see whether that's actually borne out, and obviously I'll share that with the board, not because we want to look back routinely, but I think it's really important as we get into that debate about how we open up safely. It feeds into some of the evidence that we might want to consider whether we would put forward how we open up safely. Councillor Gray?
Thank you, Sam. Sorry, I'm happy to wait, depending on what you and the chair prefer, but it's a question to do with this slide. I don't know whether you want to come back to them at the end.
Should we take questions, Sam? Because if it's relevant and we've got it on the screen, that's happy to do that.
Take it now.
Thank you for that, and it's very much about that data analysis. And thank you for your explanation, and also the suggestion that we're doing further work. When you are looking at some of those potential similar councils, I wonder whether we should consider, as well as geography, deprivation, housing tenure, and density, because there are some clear visual similarities, aren't there, physical similarities, and whether or not that's borne out by our susceptibility to similar issues. I think in terms of going forward, it would be really helpful to understand everything that we can, because the numbers are sufficiently large that I suspect we might be able to draw something from it. And I know Public Health England, while they're still here, have access to a great deal of data, number crunching, and so on. And I think that might be quite a useful way of trying to slice this, because that might give us some understanding about the differences for different parts of the county. Thank you for letting me come in on that one.
Yeah, thank you. I think it's a really good point, and I have asked the team to do some of that work already. I didn't show the slide in the member briefing because it's quite technical, and I didn't think I'd have the ability to explain it adequately in public. But I'm more than happy to share it with some narrative. What we've done is we've done a similar analysis which looks at the CIPFA benchmarking. So we can compare with our Chartered Institute neighbours, if you like. So those are councils that are considered to be most similar to BCP and Dorset. And we've run an analysis which looked at whether BCP was markedly different to any of those CIPFA councils within that group. We were pretty much in the middle of the pack, but I'd be more than happy to share that as a post-meeting note, if that would be helpful. I think the points about housing tenure are absolutely well made. It's much, much harder to isolate effectively if you're living in accommodation that doesn't allow you, adequate space to isolate safely. And so the role of some of the different accommodation types, I think, is really important. But it's not just all about private rented sector. I think the role of larger houses and multi-generational houses is really important as well. So if you think about families, perhaps with older children, might be renting out rooms. All of that, I think, feeds into the mix, because what we know characterised the transmission in this last wave was it was transmission within households driving it very clearly. So points very well made. So I was just going to spend the next few slides just looking at exactly what the team's been doing in terms of the response to coronavirus. This is the kind of flavour at the moment of how we're working. And it's been a bit of a turnaround from the early stage of the pandemic, where I think a lot of directors of public health and public health teams felt a little bit as if we were sitting on the sidelines watching this national effort being stood up very, very quickly. We're now in a better place through the development of local outbreak management plans. That's been tightened as we've gone through the autumn and through the winter. And the flavour very much at the moment is local delivery, regional coordination and national support. So a bit of a reversal of the way that government was trying to support local areas in the first instance. But that translates through to more expectation being placed on local authority public health teams, but it's not just public health teams. So I pay tribute to the wider efforts of colleagues across both councils. So as we've had to develop responses to some of these interventions, it's not just the public health team. Colleagues right across the system have been hugely efficient in mobilising the resources and the assets that we need to do things like expand access to community testing. So there are more regional structures around. So we're a member of the Regional Delivery Group and also the Test, Trace, Contain and Enable Board. Those are the boards that are responsible for coordinating this regional approach, making sure that we've got consistency and we're understanding where to deliver the best value from a limited resource. And the plan that's emerging, which is the Regional Outbreak Management Plan, is very much focused on developing a regional approach to 5 or 6 important initiatives. So health protection and response, how we're responding to incidents, particularly in high-risk settings, the expansion of testing, including new technologies like lateral flow testing, the work on contact tracing, vaccination surveillance, and of course, comms and engagement and behavioural insights. So I'll take you through a few slides that just bring board members up to date with some of the work that's been done locally under those headings. So in terms of health protection, I've mentioned the impact on the team. As you may remember, the local outbreak management plan that we developed in the summer was very, very strong on making sure that we'd gone through developing a local situational awareness in response to the action cards for different high-risk settings. They have all been used extensively over the past few months. I can't think of a single setting where we've not had to draw on the understanding of those action cards and how we involve partners. So the bulk has been probably work supporting care homes and schools, but in the past few weeks we've had to support our prisons. So HMP Guy's March and the Burn both have quite serious outbreaks at the moment. Healthcare settings been very, very affected through this second wave. All sorts of businesses in the community, huge variety of outbreaks, each with their own particular issues that we've had to draw on the action cards to think through what might be the implications, and have we got people up to speed with understanding what they have to do quickly. And to cope with that, we developed a day response team. So in the early months of the pandemic, it was perhaps the more experienced and more qualified public health consultants that were holding the ring on a lot of the health protection work. That wasn't sustainable. So very quickly, we've moved to running a duty desk, which involves people from all levels of the public health team who've received training and supervision. They work under a consultant, and we manage a very, very busy inbox now, the health protection inbox, and almost everything passes through there that needs a response. They've been brilliant actually over the past few months, although they are understandably very tired now. We've also developed a consultant on call service, something I never thought we would have to do. I thought we'd moved away from that in 2013 when we changed our responsibilities. But again, having consultants on call in the evening, and particularly over the weekends, has been really helpful. So as incidents have required that sort of out-of-hours response, having that advice to hand just provides a bit of reassurance. Most things can actually wait until the Monday morning, but it's just that reassurance and talking through the risk assessments that's been invaluable. We're still providing surge capacity to Public Health England, so you may be aware that in the early stages of the pandemic, we provided around 3 or 4 public health practitioners who were trained and formed part of their duty desk. They are still providing that support, as well as support to our own day response team. They've been hugely important in how we've mobilised that surge capacity right across the region to maintain and enable Public Health England to focus where it most needs to focus. And as a result of that, we've had to use the contain outbreak funding in a couple of places to secure additional hours and some backfill within the team where appropriate. Probably mostly extra hours in terms of the public health team. We had a number of people that are working part-time who have gone back to working full-time, but increasingly because of the work required to support the comms work across the system, we've looked to backfill 2 roles within the communications team so that they can carry on doing the ordinary work of public health communications and not let that slip. In terms of contact tracing, an interesting development was this concept of local tracing partnerships. So I'll sort of talk you through that. There's a requirement now for all councils to be more integrated with the NHS Test and Trace service. So this is that example of local delivery and national support. We began making welfare calls through customer services in each council from autumn 2020 onwards. I think on reflection, we felt that there were probably limited value in the way those calls were going out. So there was very, very few take-ups of support, but thousands of calls made to people who in some cases had already been contacted by NHS Test and Trace. And the teams began to question the value of that, quite rightly so. The local tracing partnerships actually allow the teams to access the national test and trace data set much quicker, almost in real time. So one of these previous obstacles of the team calling people who may have been in day 8 or day 9 of their isolation, and it felt a little bit after the fact, has now been resolved. So the way that the system works now is that NHS Test and Trace pass anyone they've been unable to contact in what they call the sort of simpler category. So the simple contacts, anyone they've not managed to reach within 24 hours gets passed to councils per a local approach from the contact tracing team. Dorset Council went live in January, around about the second week, and BCP Council are going live from mid-February. And so far, results from the Dorset Council side show that they've been able to additionally reach 41% of people where the national teams haven't managed to make any contact. So it's really important just to recognise that's an additional 41% of people that are being reached who wouldn't have been reached before. So I think there's more value in that. It happens on day 2 of isolation. It's a much more helpful intervention, and we'd hope to build on that success, particularly when case numbers come down and the teams find it more manageable.
Thanks, Sam. Can I just interject there and just to say that I think that's, as you say, been really valuable, and also that more local, that more local touch has enabled the teams to signpost people to the local support a lot quicker. The Dorset Together work, and so if people are needing support, I understand from the Dorset Together group that they can get it a lot quicker and are more likely to want it if it's offered locally.
That's
Even
really
if it's
good
just,
to hear.
Shopping, prescriptions, things like that, because it's someone local ringing and saying, okay, we're doing contact tracing. By the way, we've also got this number. Do you need anything? I think that trust, we see it all the time, don't we? That the trust in local government, local public health is increasing, which is really reassuring. So I just wanted to give you that, you and your teams, that feedback, because, I think it's really helpful.
That's really helpful, and I'm happy to take that back.
Thank you.
And obviously, if you've been called on day 9 of isolation and offered help with your shopping, you may get a little cross.
I think people were getting a little cross, yes, a little bit grumpy. So it's nice to see that that's a lot tighter and a lot quicker. So thank you for that.
So the just a slide on testing. The current focus is on the rollout of new technologies, and particularly these lateral flow tests, which are rapid antigen tests. They look a little bit like a pregnancy test, and they work very much on the same principle of adding a reagent to a swab. The swab is used to put the antigens into the test, and the reagent reacts and then shows up with a clear line. If you have a sufficient number of antigens at sufficient concentration, that's a positive. If you don't have the antigens, then hopefully you're negative. I guess the first months was spent building this access to standard PCR testing, and previously, you may have been aware, we've reported in public that there were occasional glitches with particularly lab capacity, not so much access to the tests themselves, but particularly getting the test process. That is not the case anymore. So throughout this past peak, we were regularly testing up to 2,000 people per day per council at the peak, which are numbers which we've never seen before. And then in the past month, we've been working on, as I said, expanding this access to these lateral flow tests. Really important to understand that the way that we're using these tests locally is around test-defined, additional asymptomatic or pre-symptomatic cases. We're not using them as a test-to-release modality. So when they were first trialled in the press, there was great hope that they might be used to release people from isolation at an earlier stage, i.e. if you've been in contact with someone who's positive for coronavirus and you're told to isolate, could you end that isolation period earlier by taking a lateral flow test every day and demonstrating that you don't have antigens? Unfortunately, with evaluation of their use in practical circumstances, the tests aren't that good at correctly identifying true negative cases, but they're good at correctly identifying true positives. So in simple terms, if you are positive on a lateral flow test, you can take that as pretty good evidence that you genuinely have coronavirus, and you should self-isolate immediately and as quickly as possible. If you're negative on lateral flow tests, there's still a possibility that you might test positive on PCR, and particularly if you took a PCR test in the next 24 hours. And that's why they're not considered to be a very effective test for that test to release scenario. And that led to the suspension of the tests in schools, where the hope was that they'd be able to reduce the number of children who are being sent home because the bubble was told to isolate. Yeah. But they are good at identifying asymptomatic cases, and we're now rolling them out at scale.
Thank you.
Council employed testing.
I think Nicola wanted to come in there, Sam, if that's okay. Nicola, do you have a question?
Apologies, Nicola had accidentally leaned on her mouse. I'm very sorry to interrupt.
No
I was
problem.
making notes and budged my mouse. I'm very sorry.
So the first phase of that expansion was the employee testing under both councils, which went live in January. That's going to build to testing around 3,000 to 4,000 employees per week across both councils. And then over the next week, we are starting to scale up the wider access to lateral flow tests in the community, very much focusing on groups of people who are having to work outside of the home. That'll be going live across 8 sites across the 2 councils, plus a number of mobile pop-ups during the half-term week. We don't yet have a feel for how well this type of testing will be, I guess, accepted by the community. So there are positives and negatives. I think if you're working regularly, you may feel that it's really important that if you do have coronavirus, you get tested and you isolate quickly, but that would present difficulties for some people who may then not qualify for some of the mandatory support that's available. So we don't yet know whether that will be acceptable to all of the groups, but we're rolling it out, and we'll obviously feed back when we've got information on how well those tests are being taken up. But I think it's an interesting development, and I'll show you a slide in a minute which sort of puts it all together. Just a quick few notes on vaccination. We're supporting Dorset CCG in mobilising and delivering the vaccination offer. We've got a couple of consultants, Rachel and Jane, are members of the vaccination cell. There's a specific work stream now starting in earnest around supporting inequalities and uptake, and a couple of the members of the public health team who've been doing some work on behavioural insights will be joining that health inequalities cell and looking at where we need to perhaps develop different offers or use different groups to explain the benefits of vaccination. So that's really exciting, and it feels a little bit more akin to that sort of more detailed approach to vaccination now that we've got through this first big push of vaccinating the first 4 priority groups. The team have also been looking at linking with the voluntary sector support to mobilise that hyperlocal delivery, which has been really, really effective. And one of the initiatives which is going live in the next week is tentatively called Cabs for Jabs, but we're looking at COVID-safe subsidised transport to and from vaccination centres and or primary care for those without transport. So again, this isn't just the public health team. Huge thanks to colleagues across both councils who supported the thinking in getting that service up and running very, very quickly. We continue to do some work around behavioural insights to overcome vaccine hesitancy. The most recent work was supporting the learning from adult social care teams when they've been vaccinating frontline teams working in care providers, and we're continuing to work on the Trusted Voices programme to develop an increasing set of resources that can be used to give the facts about vaccination in a way that perhaps people might find more relatable.
Sam, can I just ask a quick question on those last 2 slides around vaccination programme and around the testing?
Sure.
And then the question really covers both of them, and it's could you I'm just very aware that sometimes we hold these public meetings and then perhaps a member of the press is watching and they take away some of the positives and negatives from the meeting and helpfully actually cover it for us. I wonder if you could just touch on how we're proactively communicating this, so particularly around you mentioned we'll have a chance to see how those working groups will react to being able to access regular testing. So my question is, how are we actually telling them about it and communicating that? And also, I think that the work that's going on, this particular slide that's up at the moment on vaccination, I know that a lot of people might benefit from a lot of these things that are going on without even knowing about it. But I also think there's a value in knowing about it. So I just want to understand how that's being communicated to people in a normal voice way, not in a jargon way.
It's a really good point, and I think obviously our comms team have been working alongside both councils and other groups in the system to communicate some of these initiatives. On vaccination, there's a stakeholder bulletin which goes out regularly to partners. I think it's really important that some of these initiatives are highlighted within that. So we will make sure that that's included in the stakeholder bulletin. And we
Brilliant.
provide regular briefings for the media as well. And I know that some of these initiatives go out through our social media channels. And I've got a slide on it, and you'll be
of course you have.
Surprised,
Of
not
course you have.
surprised to hear further on in the presentation. But it's a really good point, because there's so much going on sometimes that we do need to pause and think about how we communicate these offers and resolve any confusion sometimes about who may be eligible, how do you get support, how do you take up those offers,
and where do you get it as well? Because I think, you know, a lot of people at the moment are kind of baffled, you know, what's coming from central government, what's coming from local authorities, what's coming from public health, what even is public health? You know, I think that, you know, our comms team have done a fantastic job in Dorset and BCP, I have to say. Yours and ours collectively have done a great job of all being on the same page, and I think that really, really helps people to understand where they can get that information, you know, from the right place at the right time. And so I really I don't think we can highlight it enough in these public meetings, you know, just to say that that the information is out there and really show people how we're driving it out. But if you have a slide on it, I'm very happy to wait for your slide. And I'm sorry for anticipating your slide.
No, it's a good reminder. And it's a good reminder that sometimes we do need to break this down for the public as well. Yeah. So surveillance and intelligence, just a couple of quick points. We've run what's called EPICEL on behalf of the Strategic Coordinating Group. So that's the gold command of the Local Resilience Forum response to coronavirus. The main focus of that group has been modelling, particularly forecasting the near-term impacts on hospital capacity. But we also increasingly look at the analysis of cases and settings to try to guide where we need to intervene more quickly. And mostly that's comms and engagement activity. And then I was just going to show a slide that was developed over Christmas when we're thinking about putting some of these interventions together. With the shift in emphasis, if you like, to local delivery, and particularly the deployment of rapid testing, when cases come down and they're a lot lower in the population, we've got a chance of developing this type of model as we go forward. So we've got a very effective cluster and network analysis tool now. This picture here, which sort of looks like the Death Star, is actually showing a cluster of coronavirus cases all linked to one setting. So we've got a quicker way of analysing outbreaks and the impacts of clusters. From that, we can understand who's affected. Councillor Green, you mentioned the importance of housing tenure before. That's a key part. We look at geodemographic segmentation tools like Mosaic to look at whether particular household types are more represented. And then we can start to think through what are the characteristics of people and how would any comms be planned in a way that would be more relevant and relatable to those groups. But the hope is that through local contact tracing, as we develop local tracing partnerships and we can deploy rapid testing more quickly, can we move much more quickly to test quickly when we identify outbreaks, test the next ring of contacts using lateral flow testing, identify any positive cases very, very quickly and get people to isolate much, much quicker than perhaps several months ago when people would have to go for a PCR test, maybe wait for a day, perhaps more than a day in some cases to get the results. It felt as if the system was a bit more sluggish. I don't think that's the case going forwards, and that's the model that we'll be hoping to develop over the next couple of months.
Nicola, you had a question on this slide.
Yes, thank you. It was an observation, really, and it was something I was going to draw out in the finance paper, where there is an allocation towards supporting the work of EPICEL, but actually it's much more relevant now. We've got something in front of us, something that actually speaks to why it's important, and obviously I'll be supporting that, but I just think this sets out so well what the point of collecting that data is, what the point of asking the questions about, so who is currently vulnerable to picking up coronavirus, where are our clusters, what are they based around? Is it work-based? Is it geographic? And that has informed, along the way, just small examples of where we put those mobile testing sites back in the autumn. So we went to the universities, and then we thought, actually, we can't just we need to have our testing where people can access it. So we've gone to geographic areas, we've gone to areas of deprivation, and we've targeted the engagement with the public. And I think I am certainly at risk of just talking rather obliquely about our comms message, but actually what is important is that we are using the data that we get through these type of resources to inform decision making, to inform the information that we pass to our residents in order to take through that responsibility to inform and protect them. And this is just it. I find it so helpful to see this slide, because in my other world of children's services, the big question is always, so what? So we found this out. So what have we done with it? So what difference have we made? And you will always know that there is more you can do, and you will always look back and think, well, perhaps we could have done this slightly differently. But actually, I think it's really important that the public or anybody who hears the message is that information is constant. I have never seen daily updates in any of the work that I've ever done. In the way that this is coming forward, and real-time decisions are being made, which are helping to protect the people who we represent. So it's when we get to the finance, it's also how are we spending that awful expression, public money, on making sure that the population are getting the service that they deserve, and that the money is being spent in a relevant way and in an informed and insightful local way. So sorry, that was slightly on my hobby horse, but I do think it's really important that we remind ourselves why it is that we do this. And in a constantly moving and evolving situation, we look back at going into second lockdown as though it was some historical era, which is so strange. And it was just, 2 months ago, because that's how quickly things are moving, but how far we've come from there in terms of providing testing. Thank goodness for the vaccination to all the people involved in trying to reach out into our communities. We know we've got further targeting to do, but also already looking ahead to when that is making an impact. We know that testing and tracing is going to be the way in which we maintain things at a lower level. So thank you, Sam, so much for the update, for the team and the work that they're doing to crunch all these numbers, but to locate the cases. And every time we talk about a case, it's a person, it's a family, it's a household, and it's potentially a whole community. And I'm so glad to see this all in one place. Thank you.
Yeah, thank you, Nicola. That's such important points to make there, and thank you for making them so well. Back to you, Sam.
Just one or two more now. We're wrapping up. So comms and engagement, we talked a little bit about this. We've led the response on the public health communications, but obviously that's only one part of the huge breadth of comms that's required. So the comms team have been brilliant. They've worked very, very closely with both councils and the wider health and care system to make sure that we're very clear and consistent on the messaging and how we get that messaging out. Just a flavour of some of the delivery methods. We produce regular video briefings, not just from myself, but other members of the team, and also increasingly trusted people from the system, and including frontline workers who will quite often talk about their experience of testing, which I think is really, really important. We've gone to 3 times weekly data briefings being trailed via social media channels, not just through Public Health Dorset, but through both councils, and regular campaigns through the Warning and Informing group, which particularly are used to pick up on the trends and the issues identified from learning from outbreaks. So we gather a lot of partner insight, if you like, through meetings like the Health Protection Board. And if we pick up that there are particular themes that we think are important in transmission, whether it's being a bit more relaxed around social distancing when you've clocked off your shift, we will start to develop campaigns in response to those themes and to develop content that can be shared through partners as well. Talked about regular media briefings. I think they've gone down really well. We've occasionally done live Q&As, both with myself, with elected members and other leaders in the system. I do a regular radio slot on Radio Solent, which seems to be going down quite well, just a quick check-in every Friday. And we regularly provide content to other radio partners as well. Stakeholder briefings, I've mentioned, they're a really important way of getting some of these developments out and known to partners. And then finally, I'm the regional lead for behavioural insights through that regional delivery work. And we're doing some work at the moment with the University of West of England on developing insight to help transmission be better understood by particular groups. And then the last slide, just to sort of finalise on some other issues for the service. We have done some other things as well as coronavirus, but it is dwarfed, I'll be honest, by what we've been doing. We mentioned the importance of business planning, so we will come forward in May with a reorganised business plan and a reprioritised work programme, which is perhaps more focused on the things that we're confident we can deliver. We have supported the development of suicide prevention plan for BCP Council, and a similar plan's in progress with Dorset Council. We've continued the system prevention work, particularly focusing on increasing awareness and understanding of being more resilient and the development of resources to support people's mental health and well-being. The Psychology Hub was recently launched. I think that was launched in January. This is a resource for the health and care system in its widest sense to access psychology support, but also a range of prevention resources. So that builds on a lot of the prevention at scale work that was started perhaps 2 or 3 years ago. Live Well Dorset continues to develop as a service. This board has seen and has approved some of the procurement to continue the work on the digital platform. That's hugely more used and has been hugely more used throughout the pandemic. And I think that would be a good focus of the report in May. We're due to consider health improvement services, and I think it would be good to come forward and show you just how well the service has been used digitally throughout the past year. And then drugs and alcohol, I think, will be a big focus over the next year. So supporting a new model in both councils. We're thinking differently about how we provide and procure services. And there's new additional 1-year funding, which has just been announced from Public Health England to support particularly getting rough sleepers into treatment. So it's very, very early days of the announcement of that funding, but we're starting to consider how we would make best use of that resource in the system. And then finally, I'd just flag the inequalities work. As the integrated care system continues to develop, it's a sort of level 1 priority, if you like, for the systems partnership board. So we continue as a team to support Patricia Miller, who's the SRO for health inequalities, in thinking through what we can start to do to perhaps reverse some of those differences in outcomes that we see in our more deprived and vulnerable communities. So that was all from me. Sorry, it's a bit of a long canter in the end, but I thought it was important just to bring us up to speed.
No, I think it's really valuable. Thank you, Sam. That I found that incredibly valuable. Nicola.
Thank you, Laura. Just to go back really to where we started in terms of the work programme that we've got coming up, and the very last point that Sam made was one that he made at the beginning, and I do just think we need to bear it in mind. And it's around the work that's going on with the integrated care system across Dorset, because clearly that's a big piece of work, and it seems to be predicated on the basis of, if you want something doing, give it to a busy person, or in this case to a very busy sector. So while those discussions are going on elsewhere and the governance sits elsewhere, it's something that I think as the Joint Public Health Board we need to be mindful of, given the timing. I think you said April 22, Sam, but there is a lot of work that's going to be taking place over the summer and autumn. And so I do think within our work programme, we'll need just to be mindful of that context.
Yeah, absolutely, Nicola. I completely agree. Do we have any other questions from anybody on Sam's report? I think I've really appreciated that detail, Sam, and the reassurance, and it's certainly a huge amount of work going on. And I just think it's useful to highlight that, receive it, and understand it, really. I'm particularly interested in the last slide in the mental health work that's going on, because we know that, you know, we've had more contacts. We know that, you know, mental health is going to be an issue, not just for, you know, frontline staff that have been working under pressure, but also for residents who have really struggled with lockdown, or struggled with financial issues or health issues, or anything really. So I'm really keen that that's also a focus for the future, although obviously it doesn't solely rest with public health. Okay, well, if there aren't any more questions on that, then shall we move through to the finance report, please? And that's item number 9. So if we go across to that, please. Is that you, Sam, or is that Sian?
It's me. Thank you.
Sian, you're very welcome.
I'm just going to share a few slides, if that's okay. Sorry. So you will note from previous meetings that the public health grant in 2021 grew by £900,000, taking the total grant for just over 14 million. This gives our 2021 shared service budget is currently 28,748,000. The current provisional forecast for 2021 is £1,388,858, and this is due to the COVID-19 pandemic that has substantially changed the way that public health services have taken place this year. The forecast takes into account non-COVID related cost pressures, including additional demand within drugs and alcohol services. The agenda for change uplifts for NHS contracts currently estimated at £350,000 full year effect, as well as COVID full year impact, an assumed reduction in the NHS health checks, adaptation to services to make them COVID secure, and the modelling of the data science and support EpiCell work, which Sam talked about previously. The forecast may not fully take account of apportionment of COVID-related costs, suicide prevention and bereavement support, and further ongoing reductions in activity within community health services due to the ongoing restrictions due to COVID. Again, as previously mentioned in previous meetings, each council retains an element of the public health grant. So you'll see here BCP retains 4,472,000 to support drugs and alcohol services, children's services including children's centres and early intervention work, and central overheads, and Dorset Council retains £617,000 to support the community safety team and adults housing work, community development and customer services, and also children's early intervention. Our reserves currently sit at £910,600, which is made up of £617,000 for prevention at scale, and uncommitted reserves is £293,600. Previously in meetings, we'd agreed that £500,000 would be the minimum, so we're currently below that. It's not anticipated that any reserves will be used for 2021. So looking at the budget for 21-22, the grant allocations for public health in 21-22 have not been released yet. There is an indication that this year's uplift will be maintained, and that the 21-22 budget is therefore built on assumptions that the public health grant and each local authority will remain the same as 2021. It's recommended that from the underspend in 2021 of the 1,388,000, that 388,000 of this is applied to the shared service budget for 21-22 as a contingency to support the restarting of potential catch-up of health improvement services in 21-22, which have been delayed this year. It's also recommended that the remaining £1 million of that forecast is used to reduce the proportion that the local authorities provide in 21-22. This means that BCP would have a reduction of £532,000 and Dorset Council £468,000 as a one-off contribution. Based on the combination of 1920 and 2021 forecasts, the provisional budget for 21-22 has been set at the 28,132,500. This assumes a return to normal activity within the current activity contracts, no change in arrangements to the drugs and alcohol services, and full year effect of the agenda for change agreements that are currently taking place in 2021. So the recommendations for this finance report is that we note this report, agree that the use of 388,000 of the anticipated 2021 underspend is used as a contingency to support services next year, agree the £1 million anticipated underspend to reduce local authority contributions next year, approve the provisional budget of the shared service for 21-22 at 28,133,000, approve Appendix 2, which will form the financial annex of the shared service partnership agreement for 2021-22, which we saw at the last meeting, and agree the proposal to extend the current Bournemouth Pool and Dorset Alcohol Drugs strategy for 2016 to 2020 for a minimum of another year. Following LGR, both councils adopted the pre-existing Bournemouth Pool and Dorset Alcohol and Drugs strategy. As a result of the ongoing additional pressures that the pandemic has created, the work to develop a new strategy hasn't currently taken place. The recommendation is that the current strategy is extended for at least a further year to allow this time for the work to be developed on this.
Thanks, Sian. Okay, so there's a couple of things to unpick in there, really, isn't there? So let's have a look at the recommendation. Can you leave the recommendation up?
Sorry, yeah.
That's all right.
Sorry.
Only so I can use it as a little visual reminder. Brilliant, thank you. So I think, I mean, certainly I'll take questions if anyone has any questions. I think the use of the 388,000 to support the restart, certainly that sounds like a very good idea. We don't want to get behind, and you know that extra funding will be needed. The remaining £1 million, I think, would be a very welcome reduction in local authorities' budgets and contributions, given the COVID-related hole in our budgets that we seem to have, although we're working very hard on reducing. The provisional budget seems to me sensible. And as does extending the alcohol and drug strategy for a minimum of another year. I think I would be nervous in moving to a different strategy without significant and proper time given to the work on that, which of course at the moment we don't really have. So these all seem sensible to me, but I've got Jan. Jan, would you like to come in?
Yes, I just wondered whether Sam could just confirm what conversations has happened with the Section 151 officers in both councils, given obviously this ties in with the MTFP, the medium-term financial plans, which are being taken through by both authorities. So it's just about confirming that this is in line with the medium-term financial plans as being agreed by both councils.
Yeah, thanks, Jan. I was going to just highlight for the board, you may or may not have noticed in your inboxes that we reissued the finance paper. So I consulted with both Section 151 officers, particularly around the intention to reduce the service contribution for 21-22. So in the paper as originally written and on the slide, it's quite right that we've intended to reduce the service contribution from BCP Council by 532,000 and from Dorset Council by 468,000. At the moment, for a range of reasons, I've flagged with both Section 151 officers that we are not intending, we may not hit that forecast amount. So I flagged it for budget monitoring because obviously the budgets have gone through scrutiny. We've set that figure in the MTFP for 21-22. So if all things are kind of develop in the way that we would anticipate, we will be able to make that contribution by the end of 21-22, but we couldn't hand on heart commit to that forecast in this paper partly because of the uncertainty around the final grant determination for 21-22, but also particularly around health checks. We're still not clear what the requirement will be when we start up delivery again. So it's just a flag to the board that we will be monitoring this through budget monitoring throughout the year. I'd hope that further on in the year, when the forecast becomes firmer, we can continue to commit to the figures in the MTFP, but we've flagged it as a risk and we'll continue to monitor it.
Brilliant. Thank you, Sam, for the clarification. That's really helpful. Vanessa Reid.
Thank you. Thanks, Sam. Just in terms of the underspend, I just wonder if this is a conversation that also should go through the SPB or SLT for awareness of the proposal recommendation. Just bearing in mind the conversations we've had earlier during the meeting about the ICS and the importance of prevention. So I'm just really curious about the contribution that is a reduction is will that be redirected to public health and prevention services? So, yeah. So I think that's something that probably the SLT would be very interested to understand, and the ICS as it develops.
Yeah, thanks, Vanessa. I'm more than happy to share. Obviously, these are public papers. The board papers can go to SLT or SPB. I think it's really important to remember the context of why we're trying to change under the partnership agreement from a situation where quite often at the end of the year, we may have made savings and we would pass those savings back to partner councils in an unplanned way. It still remains the case that all of the spend through the public health grant has to be spent against activities which will result in an improvement in public health. So there are very, very clear grant criteria. And by moving to developing a provisional budget in advance, we're hoping to be able to build up a recurrent pot for investment by councils, but still within the grant criteria. So to me, I think it makes it a bit more transparent, and hopefully the system will be able to, review and comment on those priorities as well. So I think it's a sensible suggestion.
Thank you, Sam.
And thanks, Vanessa. I think that's really interesting point, isn't it? And I would hope that as we go forward, we can really sort of hone the process so that it is transparent, Sam, because, that's all our ambition, isn't it, really? It's just about the steps that we take and clarifying those so that we all know exactly the process that we need to go through. And I think we would all welcome that. Any other questions from anybody, or Sam, any further points that you want to make? I think that was really, really helpful. Thank you, Sian. So our recommendations are to note the report and then to agree those 1, 2, 3, 4, 5 points. Can I take those as noted and agreed by the board?
Agreed.
Thank you.
Agreed.
Fantastic. Okay, I've got a funny feeling that brings us to dates of future meetings. We've got proposed the Thursday the 20th of May, the 15th of July, the 18th of November and the 10th of February 2022. Gosh, that seems like a long time away, but no doubt it will fly. So those dates are proposed. They're noted, I guess. I think they're already in our diaries because David is horribly efficient. So thank you for that. Let's have a look.
Yeah, Chairman, could I just say, before I did anything concrete, I want to establish that there was no concerns over those dates, or given the fact we've only got 4 members, say 2 or 3 couldn't make it, then
yeah,
we'll have to look at something else. But now we've established that, I'll go ahead and make those dates.
Oh, brilliant. Okay, thank you, David. That's fantastic. Maybe it was a provisional hold. Either way, we've got them. So that's really good. So we can plan for this year. Gosh, getting my years wrong. Okay, so I think the final item on the agenda is any urgent items. I have had none. And therefore, I'll just quickly check with my officers. We haven't had any that I'm not aware of. Any urgent items, David? No, nothing. Didn't think so. Fantastic. In that case, thank you all for joining this morning. I think that's been really, really helpful update. I found that incredibly helpful. I always find it interesting when we can have these meetings in public and really shine a bit of a light on the work that's happening and get the chance to ask those questions. So I'm grateful. We did have the meeting in for 3 hours, so I give you the gift of nearly 2 hours back in your busy little diaries. And if anybody was listening in, members of the public or press, thank you very much for joining us as well. And we will see you again in May. Take care, everyone.
Bye.
Thank you.
Thank you.
Bye.
Thank you very much.